So then let's get into the actual drugs that act within the autonomic nervous system. So first of all, drugs that act at cholinergic receptors. These will be drugs that either activate or block cholinergic receptors. Those that antagonise the action of acetylcholine we refer to as anticholinergic drugs. And just by convention, we're talking actually about those that antagonise the action of acetylcholine just at muscarinic receptor sites. So anticholinergic drugs are muscarinic receptor antagonists, or occasionally you'll also hear antimuscarinic drugs. We don't use the word anticholinergic for drugs that block nicotinic receptors. So just by convention, we only use anticholinergic for muscarinic receptor antagonists. And the most common way we refer to these muscarinic receptor antagonists is as anticholinergic drugs. If you take anticholinergic drugs, that means that acetylcholine can't bind to muscarinic receptors and cause a cholinergic effect. So that means the parasympathetic nervous system can't influence any of its effector cells, because it's always there using acetylcholine on muscarinic receptors. So antimuscarinic, also known as anticholinergic, is an anti-parasympathetic action. Another word you could use there as well is parasympatholytic, which we just mentioned because it's an awesome word. Parasympatholytic. So all of these different terms, muscarinic antagonist, antimuscarinic, anticholinergic, parasympatholytic, all talk about the same thing. They're blocking the effect of acetylcholine on muscarinic receptors, and so blocking the parasympathetic nervous system from being able to cause any of its effects around the body. In the opposite case, where we have agonists of cholinergic receptors, we call that a cholinergic action. So agonists of muscarinic receptors will lead to a mimicking or an increase in a parasympathetic effect around the body. So cholinergic action, increased parasympathetic response, anticholinergic action, blocking the parasympathetic response. So cholinergic drugs, those muscarinic receptor agonists, are going to mimic the effects of the parasympathetic nervous system. We can also then refer to these as parasympathomimetic, another great word, parasympathomimetic drugs. We don't use these very often clinically. We've got a drug called bethanechol, which is used mainly for urinary and gastrointestinal symptoms, and a few similar ones as well. So these would be used to do things like promote gastric motility or promote micturition, emptying of the bladder, by stimulating muscarinic receptors in these places, stimulating the parasympathetic nervous system's normal effects of promoting digestion or promoting urination. And then we've got a couple that are used locally, carbachol or pilocarpine. These are used in glaucoma, where you have increased pressure in the anterior cavity of the eye. And here in the eye, these are going to stimulate contraction of both the pupil muscles and also stimulate contraction of the muscles controlling the lens, the ciliary body muscles. And in doing so, that can relieve some of the pressure that's built up from excessive fluid in the front of the eye. And so relieve the symptoms of glaucoma and relieve the damage to the eye that pressure can be causing. So these cholinergic drugs, the adverse effects are going to be effects of too much sympathetic activation around the body, parasympathetic activation around the body. So you'll see miosis, that constriction of the pupil. You'll see nausea, related to effects in the gastrointestinal system, and diarrhea as well, both from excessive motility, a urinary urgency from contractions of the bladder being caused, and also diaphoresis or excessive sweating. Sweat glands are innervated by the sympathetic nervous system, but it's that weird part of the sympathetic nervous system that actually uses cholinergic neurons acting on muscarinic receptors. So these are just effects, caused by acetylcholine on muscarinic receptors. And when you're using a drug to cause just some of these effects, you're going to cause all of them at the same time. Bit more common in medicine is anticholinergic drugs. So these are muscarinic antagonists, and we've got quite a range of these, but still the most well-known ones are a couple of naturally derived drugs, atropine and hyoscine. Atropine is a compound that originally derived from deadly nightshade. So that plant is Atropa belladonna, and it contains atropine. And then hyoscine is derived from plants like henbane and jimson weed. You might have also heard of that by the American for hyoscine, which is scopolamine. So we also have a number of synthetic drugs that have similar effects. For example, we'll cover ipratropium when we look at asthma management in session 13, and that's an antimuscarinic or anticholinergic drug as well. So we'll look at atropine most particularly, as that's sort of our archetype of antimuscarinics, and any other drug that can have anticholinergic actions, we usually refer to those effects as atropine-like effects. And atropine itself has a long history of use in modern medicine and an even longer history of use in traditional medicine as well. So for example, one historical use of atropine, or of nightshade plants in particular, was belladonna, causing mydriasis. So parasympathetic nervous system normally causes meiosis or pupil constriction. Anticholinergic drugs then cause pupil dilation, and that sort of mimics the dilation of the pupils you would get as part of a sexual response, and so it was thought to make people look more attractive. So there was long periods of time, there were times in history at least, where women used to put drops of this in their eyes to get these blown pupils, and that was called belladonna, or beautiful lady, because of that effect. So as well, though, if taken systemically, you're going to see not just effects at the eyes, but effects on everywhere that the parasympathetic nervous system innervates, and also that weirdo bit of the sympathetic nervous system to the sweat glands. So you're going to block those effects of acetylcholine. So you'll inhibit secretions of skin and mucous membranes. This is a major use of atropine-like drugs in modern medicine, where they use them to inhibit secretions of the airway when you have people who are intubated, and where that tube can irritate and cause excessive secretions in the airway. Try and limit that. You'll use atropine-like drugs. In the respiratory system, it will relax muscles of the bronchial tract, opposite to the parasympathetic. In the cardiovascular system, low doses will decrease heart rate. That's from a central nervous system effect in the brain. High doses, though, will block the parasympathetic nervous system from slowing the heart rate, and so will increase heart rate. High doses will inhibit gastrointestinal motility, and in the urinary tract, you'll see a relaxing of the smooth muscle of the bladder wall, but an increase in sphincter constriction. So you'll limit urination. And these will also affect, atropine and other similar compounds will also affect the central nervous system, blocking muscarinic receptors there to cause excitement and mania. As a sort of summary of these effects, and particularly useful in diagnosing nightshade poisoning, you hear a number of mnemonics that help to remember the constellation of effects that come from anticholinergic agents. So you hear things like mad as a hatter, blind as a bat, dry as a bone, red as a beet, but the heart runs alone. Things like that. So basically talking about mad as a hatter from the excitement and mania, the pupil dilation and effects on the ciliary muscle and the lens can make blurred vision, and so on and so forth, summarising these different effects. We can compare cholinergic and anticholinergic agents by seeing that they, by either activating or blocking parasympathetic input into various tissues, they'll have about opposite effects there. So pilocarpine, one of your cholinergic agents, you'll see will cause the parasympathetic-like response of meiosis at the eye and cause constriction of the pupil. Whereas Atropine, as an anticholinergic, would there cause dilation, the opposite of what the parasympathetic nervous system normally does. Our other major anticholinergic agent that we're looking at would be hyoscine, usually formulated as hyoscine hydrobromide. So this is indicated usually for motion sickness, where it can prevent nausea and vomiting by a combination of the gastrointestinal adverse effects and also particularly central nervous system effects, or as an adjunct medication with anaesthesia to reduce respiratory tract secretions like atropine that I mentioned before. So very similar, hyoscine is very similar in structure to atropine, it's a very similar compound. And so it causes most of the same effects, but it has much more central nervous system effect because it much more rapidly crosses the blood-brain barrier. So you see much more of things like euphoria and also other central nervous system effects of drowsiness, memory loss, relaxation, sleep, relief from fear, and overall it tends to depress central nervous system function. It does so and doesn't increase any blood pressure or respiration as well. Now, those are the anticholinergic agents that we'll cover, but it's important to note that a lot of other drugs happen to be able to block muscarinic receptors as well as their primary effect. So anticholinergic adverse effects is something we'll hear a number of times over the semester. For example, antihistamines, though they are taken for their effect of blocking histamine receptors, almost all of them have at least some ability to block muscarinic receptors as well. And tricyclic and tetracyclic antidepressants have effects on serotonin and noradrenaline in the brain, but also happen to be able to block muscarinic receptors too. So for any of these, as well as the actual anticholinergic agents like atropine, you see a typical constellation of anticholinergic adverse effects, including tachycardia and palpitations from increasing the heart rate, decreased bronchial secretions, antispasmodic effects, mydriasis from the expanding pupil and blurred vision from the effects on the ciliary muscles, dry mouth, again that's drying up the secretions, urinary retention from effects on the bladder. You'll see this male impotence probably because that's most obvious, but you'll see a failure of tissue arousal and tissue erection in both genders. Decreased gut motility that can lead to constipation and dizziness as well. So these are your typical anticholinergic effects, and they can happen with drugs, even those that we don't take for the express purpose of blocking cholinergic receptors, but that happen to also be able to block cholinergic receptors. So because of that, our anticholinergic drugs will interact with any of these other drugs that have those anticholinergic effects as an off-target adverse effect. So the tricyclic antidepressants and antihistamines, particularly the older ones like promethazine, which is your Phenergan. Because they will reduce gastric motility, they also tend to impair the absorption of other drugs. In terms of warnings and contraindications, you shouldn't use anticholinergics in things like myasthenia gravis, autoimmune attack of cholinergic synapses, any severe cardiac disease where tachycardia could be very dangerous, same for gastrointestinal obstructive diseases where you don't want to slow gastric motility. Also narrow angle glaucoma, a rarer form of glaucoma where you don't want to cause contraction of the pupils dilation of the pupils in that disorder. Its use is cautioned in Down syndrome in the elderly and any hepatic or renal disease where you tend to get increased effects or increased central nervous system effects at least from these anticholinergic drugs.